Next topic comes under the heading diseases complicating pregnancy is liver diseases during pregnancy or jaundice during pregnancy. We know that jaundice is a common clinical condition. Jaundice may occur during pregnancy also. So, what are the special care we should take if a pregnant lady gets jaundice or if a pregnant lady gets liver diseases? What are the different types of liver diseases that commonly seen during pregnancy, and how can we manage this condition? If there is any difference between the management of jaundice of non-pregnant woman and management of jaundice of pregnant woman. Today we are going to discuss all these things. There are three types of liver diseases that are commonly seen during pregnancy. The first and most important one is liver diseases that is peculiarly related to pregnancy. The importance of this condition is it resolves following delivery. So this type of diseases seen only during pregnancy and it resolves following delivery. So we can say that these conditions are related to pregnancy, or pregnancy predisposes to some particular liver conditions. The second one is the viral infections unrelated to pregnancy or coincidental liver diseases, mainly viral infections. And the third one is chronic liver diseases. The first two are important, and we are discussing only the first two things. There are mainly 4 diseases of liver which is directly related to pregnancy or peculiarly related to pregnancy. These are intrahepatic cholestasis of pregnancy, acute fatty liver of pregnancy, hepatic dysfunction from hyperemesis gravidarum, and hepatocellular damage due to preeclampsia or eclampsia. First one is the most common one, that is intrahepatic cholestasis of pregnancy, and it is the second most common liver diseases during pregnancy. The most common liver diseases during pregnancy is viral diseases, but viral hepatic diseases are not directly related to pregnancy. Here this intrahepatic cholestasis of pregnancy is directly related to pregnancy. The next one is the acute fatty liver of pregnancy. Then the third and fourth condition, we already discussed the third and fourth condition while discussing hyperemesis gravidarum and eclampsia. Hyperemesis gravidarum, if uncontrolled or untreated, that may lead to some liver functions or that may lead to some liver dysfunction. Similarly, preeclampsia and eclampsia, if not treated properly, may damage the liver and it may cause some liver diseases. So hyperemesis gravidarum and eclampsia sometimes lead to some liver diseases. The first condition is intrahepatic cholestasis of pregnancy. We already seen that it is the second most common cause of jaundice in pregnancy. The most common cause of jaundice in pregnancy is viral hepatitis. Stasis of bile in the bile canaliculi with rise in conjugated bilirubin due to high concentration of estrogen. Here there will be stasis of bile in the bile canaliculi or stasis of bile within the liver that leads to liver dysfunction, and it is due to increased estrogen level. Pregnancy is associated with increased estrogen level. That increased estrogen level leads to stasis of bile within the liver, which leads to liver diseases. So it is called as intrahepatic cholestasis. Intrahepatic means within liver. Cholestasis means stasis of bile. Intrahepatic cholestasis of pregnancy. Symptoms of this condition appear during the late months of pregnancy, and the main clinical feature is pruritus, intense generalized pruritus without rash, and this pruritus is more in palms and soles and aggravation at night. This is the most important clinical feature of intrahepatic cholestasis of pregnancy. There may be mild icterus. Icterus is a common clinical symptoms of all liver diseases. Here also we can see icterus or jaundice, but it is very mild. Bilirubin level rarely exceeds 4 to 5 milligram per deciliter. The other symptoms are weakness, nausea, vomiting, lethargy, etc. These are the common signs and symptoms of all liver conditions. Here, the most peculiar clinical feature is the pruritus, intense pruritus without rash, that is more in palms and soles. And lab investigation shows there is increased bile salts. Serum alkaline phosphatase is elevated. Serum aminotransferase sometimes normal or sometimes moderately elevated. The most important clinical finding is the increased bile salt. Remember, increased bile salt is the most important clinical laboratory finding in intrahepatic cholestasis. Serum alkaline phosphate is also elevated. Regarding the management of intrahepatic cholestasis of pregnancy, there is no specific treatment in modern medicine. The important management is the management of pruritus. Pruritus is quite troublesome, so medicines are given to alleviate pruritus. Avoid OCP, oral contraceptive pills, in risk persons. Not only during pregnancy, during non-pregnant time also, risk persons should avoid oral contraceptive pills. Oral contraceptive pills contains estrogen. Estrogen increases the chance of intrahepatic cholestasis. And there is increased risk of preterm labor, meconium stained liquor, low birth weight babies, and postpartum hemorrhage. So care should be taken to manage all these conditions in a pregnant lady with intrahepatic cholestasis. Vitamin K should be given both to mother and the newborn. So there is a chance of postpartum hemorrhage. To prevent the postpartum hemorrhage, vitamin K should be given both to mother and neonates. It is routinely given in such conditions. The next condition is acute fatty liver of pregnancy. It is a rare condition, but is very lethal. It is fatal to both mother and fetus, and it is a recessive inherited condition, a recessive inherited mitochondrial abnormality of fatty acid oxidation. Here the clinical features, here also manifestation of the disease, this disease condition appear in late in pregnancy. There will be malaise, anorexia, nausea and vomiting, and jaundice. All these are the common signs and symptoms of our liver condition. And here there will be epigastric pain and progressive jaundice and coagulation failure. Coagulation failure is the important pathology in fatty liver of pregnancy, and there will be progressive jaundice. We have seen that in intrahepatic cholestasis, jaundice is mild. The next condition is hepatic dysfunction in hyperemesis gravidarum. We know that hyperemesis gravidarum, hyperemesis, that is increased vomiting. Gravidarum means pregnancy. Hyperemesis gravidarum means increased vomiting during pregnancy. That uncontrolled hyperemesis gravidarum or untreated severe form of hyperemesis gravidarum adversely affect liver function. Nausea and vomiting that leads to dehydration, malnutrition and acidosis. So acidosis is one of the main pathology in uncontrolled hyperemesis gravidarum. Here also there will be mild hyperbilirubinemia, and in laboratory investigation there will be increased transaminase level or SGPT level. We have seen that alkaline phosphatase is increased in intrahepatic cholestasis. Here in hepatic dysfunction due to hyperemesis gravidarum, there will be increased transaminase. The fourth liver conditions that is directly related to pregnant woman is the hepatic involvement in preeclampsia or eclampsia. Uncontrolled preeclampsia or eclampsia may damage the liver. The main pathology here is the periportal hemorrhage, fibrin deposition, hepatocyte destruction with necrosis. And we have learned that HELLP syndrome, HELLP, HELP syndrome, is the hepatic complication that developed as a consequence of preeclampsia or eclampsia. It is collectively known as HELP syndrome. So eclampsia or preeclampsia may lead to some hepatic complications. That hepatic complications is known as HELP syndrome. H means hemolysis, EL means elevated liver enzyme, LP means low platelet count. HELP syndrome is characterized by hemolysis, elevated liver enzyme and low platelet count. Next is the liver diseases unrelated to pregnancy or coincidental liver diseases that occur in pregnant women. So this is similar to liver disease of a non-pregnant woman. Both the pregnant woman and non-pregnant woman may affect viral hepatitis. If there is any difference between the clinical features or management or complications of viral hepatitis in non-pregnant woman and pregnant woman, that is our subject of discussion. That is our. There are mainly 5 types of viral hepatitis. Viral hepatitis A, B, C, D, E, and recently one more type, that is G. Hepatitis due to hepatitis A virus, hepatitis B virus, hepatitis C virus, hepatitis D virus, E virus and G virus. Acute phase of all these viral diseases, viral hepatitis, are similar, but the clinical course and complications are different in different viral hepatitis. A and E are the most common viral hepatitis seen. It is less complicated and it is less virulent. It is self-limiting. No fulminant hepatitis is seen associated with hepatitis A and hepatitis E. There is no chronicity. There is no vertical transmission in hepatitis A and hepatitis E. Here the spread is through fecal-oral route. But B and C are more dangerous. It is transmitted by parental route, sexual contact, and there is a chance of vertical transmission also, that is transmission of hepatitis B and C from mother to fetus. This is the most important thing while discussing about viral hepatitis. So if a pregnant woman had the infection of viral hepatitis B and C, there is a chance of transmission of this infection from mother to fetus. There is chance of chronicity and hepatic carcinoma. Neonatal transmission usually occurs during delivery time. Hepatitis D and G are uncommon and it is associated with B or C. The clinical features of viral hepatitis. All viral hepatitis are clinically similar in their acute phase, and many cases are subclinical. There will be symptoms of nausea, vomiting, headache, malaise, jaundice. All these are the common signs and symptoms of all liver diseases: nausea, vomiting, headache, malaise, jaundice, etc. There will be low-grade fever associated with mainly associated with hepatitis A. And in lab finding, there will be increased serum aminotransferase, or there will be increased SGPT. Sometimes the peak level of 400 to 400, or sometimes the peak level of 4000 unit per liter are reached sometimes. Aminotransferase or SGPT is elevated in Hyperemesis gravidarum also. We have seen that Hyperemesis gravidarum may lead to some hepatic dysfunction, and in that condition also there will be increased serum aminotransferase. But intrahepatic cholestasis is associated with alkaline phosphatase, increase in alkaline phosphatase, remember that. There will be increased serum bilirubin. Viral hepatitis are usually associated with increased serum bilirubin. And another lab finding is the presence of bile salt and bile pigment in urine. The important obstetric complications associated with viral hepatitis are: there will be abortion, chance of premature labor, postpartum hemorrhage, there is a chance of renal failure, there is a chance of hepatic coma. Regarding the management of viral hepatitis during pregnancy, management is similar to management of viral hepatitis of non-pregnant women, but care should be taken in case of hepatitis B, C and D, because hepatitis B, C and D are associated with vertical transmission. So all pregnant women should be screened for hepatitis B and C infection, and hepatitis vaccine is recommended routinely for all pregnant ladies. Then after acute phase or during acute viral hepatitis, rest for 3 months are suggested. Proper sanitation, supply of safe drinking water. Hepatitis A is transmitted through fecal-oral route, so supply of safe drinking water is a essential component of management of viral hepatitis. Follow low fat diet, avoid hepatotoxic drugs. All these are the management of viral hepatitis.